for the winner in the oral cases, inshallah. Now I'll put the floor to Rasha to start the debate, inshallah. Rasha, the floor is you.
Thank you, Osama. Assalamu alaikum wa rahmatullah, everyone. Good afternoon. So I'm Rasha Rahbi. I'm an emergency resident R2 in OMSB. And I'd like to welcome you all to today's debate, which is part of the resident track in the Research and Resuscitation Conference. So before we proceed, I'd like actually to introduce the flow of the debate. How would it run? So actually we have 2 teams, 4 members in each team, and 3 speakers will be speaking from each team. So each team, we have a proposition team, which will be debating with the motion, and then we have the opposition team will be debating against the motion. And we'll start first of all with the proposition, the first speaker from the proposition, then we'll move on to the first speaker from the opposition, and then again to the second speaker from the proposition, and so on. Each speaker will have 7 minutes to introduce whatever arguments and also for rebuttaling the arguments of the other team. And after the main speeches are over, each team will have 4 minutes to make their reply speech. So basically in the reply speech, they will be stating the strengths of their team and the weaknesses of the other team and why should they win rather than the other team. So actually, so this is mainly regarding the debate format and the flow of the debate. So I'd like now to welcome our amazing teams. We have the proposition team, the OMSB team. We have Dr. Hajar Al-Jadidi, and we have also Dr. Sarmed Salmin, and Dr. Noor Al-Alawi, with also Dr. Mizna Al-Maqrashi. Welcome all. Then also we have our guests team, the opposition team from the United Arab Emirates. We have Dr. Kulthum Umar and Dr. also Sarah Hussein, Dr. Maytha Al-Ali, and Dr. Aisha Al-Rumaithi. They are joining us from 2 programs, the Rashid Hospital Trauma Center and also from the SSMC program, emergency program. Welcome all to the debate. And I'd also like to welcome the judges. Joining us are Dr. Saif Al-Ghafri, Dr. Suad Al-Blushi, and Dr. Suad Al-Abri. They will be following the debate and marking you guys, and then we'll see who will be winning. So it would be a great debate, inshallah, beneficial. Hopefully everyone enjoys it, and we want it to be competitive. So it's your time to shine. So without further ado, introducing today's motion, our 2 teams will be debating about the early use of pressors in septic shock patients. So the debate motion is early use of pressors in septic shock patients. Our host team is the proposition, and the guest team would be the opposition. We'll be starting the debate now with the first speaker from the proposition, Dr. Hajar Al-Jadidi. Dr. Hajar, the floor is yours.
Assalamu alaikum. So welcome to the debate. We're going to talk about fluid resuscitation, initially fluid resuscitation in septic shock, where the team will go liberal and fast. Next slide. So we are adapting the definition of survival sepsis campaign, which actually defining fluid resuscitation as 30 ml per kg of IV fluid crystalloids, which should be given within 3 hours from the initial resuscitation. In fact, this statement or this definition did not change since 2016. And that's because there are no strong evidence and no strong RCTs which push the survival sepsis campaign to change it. These statements was based on a lot of observational studies and also on expertise. Next slide. So one of them is this study, which actually look at the evaluation of predictors of fluid resuscitation in patients with severe sepsis and septic shock. They conducted this observational study and they ended up finding that failure to receive 30 ml per kg of crystalloids within the first 3 hours of resuscitation increased odds in in-hospital mortality, delay in response of hypotension, and delay length of stay in ICU as well, despite any special population like in end-stage renal disease and heart failure as well. The amazing 3 sepsis triology process, ARISE and PROMISE, they also adapted in the pre-randomization status 30 ml per kg of fluid resuscitation. And that basically reflects the clinical practice and beliefs that 30 ml per kg is still safe to be used in septic shock and in resuscitation. Next slide. We heard a lot about different explanation about pathophysiology regarding excessive fluid resuscitation. You will hear about the endothelial damage. You will hear about the cardiac failure, fluid overload. In fact, there is no strong evidence behind it. One large systemic review was conducted and they collected over more than 50 studies. 17 of them looked at the pathophysiology of fluid resuscitation in septic shock. And guess what? There is no strong evidence that it showed harm based on the pathophysiology status in septic shock. In fact, all these papers that included in the systemic review, they lacked an RCT. When we want to tell that fluid resuscitation with this amount of fluid, it's harmful, we want to reflect how responsive this patient to fluid policies. So there are a lot of methods to reflect or to assess them. Few of them: capillary refill, pulse pressure, MAB, and also clearance of lactate. But actually, what about direct assessment of cardiac output in a non-ventilated patient? That's the question we need to look at. No strong RCT was done looking at the cardiac output after fluid resuscitation. Again, we are lacking stronger RCTs which showed specific amount of fluid resuscitation versus no fluid resuscitation or specific amount of polysis. We heard about these trials, which was conducted in South Africa in pediatric population. And despite the well protocol that the study had, unfortunately, we cannot apply the conclusion of that study, which showed harmful fluid polysis, because the population of that study actually, they have a high prevalence of malaria, and they were an anemic patient with hemoglobin, most of them less than 5. The result of that study was affected by these 2 points. Next slide. When we speak about special population, congestive heart failure, end-stage renal disease, liver cirrhosis, practically, we always do that. We restrict fluid polysis on those patients because we don't want to push them into fluid overload. In fact, there are multiple observational studies. These 2 studies are one of them. It showed depriving these patients with septic shock from 30 ml per kg of fluid polysis, it worsens the outcome. In fact, none of these, like in end-stage renal disease, giving them 30 ml per kg of fluid polysis in septic shock did not push them for early dialysis or urgent dialysis or early intubation, as well as in heart failure. In fact, Survival Sepsis campaign, they advocated and they recommended the similar amount of fluid resuscitation in these special population as the rest of septic shock patients. This is all, and thank you.
Thank you very much, Dr. Hajar. You spoke in 4 minutes and 50 seconds. We'll move on to the first speaker from the opposition, Dr. Kulthum Umar. Please start, Dr.
Okay, Assalamu alaikum, everyone. I'm Kulthum, 4th-year emergency medicine resident in SSMC Abu Dhabi. So my team and I will be arguing about against early pressors in septic shock patients. I will briefly discuss on slow and conservative fluid therapy. Sarah will talk about a target map of 60. And lastly, Matha will discuss timing of pressors. Next slide, please. Okay, so in order to adequately resuscitate patients with fluid therapy, we first need to understand the basic physiology and what it is we're trying to target. So we have what is the macrocirculation, sorry. This is composed of your cardiovascular system, your large arteries, and your large veins, which is reflected by your systemic hemodynamics. This is your cardiac output, your MAP, and your central venous pressure. This is what most people try to correct. Then you have your microcirculation. This is made up of your smaller capillaries, venules, and arterioles. This is responsible for oxygen transfer, which tells us more about your tissue perfusion. And this is what we should be targeting to correct in septic patients. So to assess the microcirculation, we look at multiple things like lactate clearance, central venous oxygen saturation, etc. Next. Next again. Can you show the full circle? Thank you. So septic shock is a type of distributive shock, right? So when you see a hypotensive septic patient, what do? You give them a fluid bolus. This transiently improves their blood pressure, but because they're so vasodilated, the fluid leaks out into the interstitium. And studies have shown that in healthy volunteers, 70% of this fluid bolus leaks out within 30 minutes. This can result in interstitial edema, renal edema, intestinal edema. Eventually, the patient becomes oliguric, hypotensive, appears dry. What do? You give them another bolus. And this is a vicious cycle that just goes on and on and on. So what do you end up with? You end up with a patient with fluid overload, pulmonary edema, ARDS, and the list goes on. So what are our fluid boluses actually doing to the patient? Are they causing more harm to the patient? What's the problem here, basically? Do we need to fill the pipe, which is the blood vessels, or do we need to support them? This is what we need to understand. Next slide, please. Next, 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 and next. Thank you. So this 30 ml per kg, why this golden number? So the Survive in Sepsis campaign recommendation published this month earlier says that this is a weak recommendation with low quality evidence, as most of the data from this was derived from observational studies or routine clinical practice. There are actually no large randomized controlled trials supporting this 30 ml per kg. And if you compare this to the 2016 guideline, this is actually a downgrade because this was previously a strong recommendation. So why did the downgrade happen? Did the evidence suddenly disappear? Did something new come up to disagree with this 30 ml per kg? Next. So this is a quote I thought would be interesting to share here. So basically, the fact that an opinion has been held is no evidence whatever that it is not absolutely absurd. Next. So the interventional studies that this Survive in Sepsis campaign guideline references are actually the average volumes of fluid given to patients in the PROCESS trial, the ARISE trial, and the PROMISE trial. So these were all randomized controlled trials, all unblinded, that were conducted over the course of several years. And the clinical question they looked at adult patients with sepsis to see if early goal-directed therapy or protocol-based care versus standard care can reduce mortality in 60 or 90 days, depending on which trial it was. Next, 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 next. Thank you. So these trials were not without problems. For example, the PROCESS trial changed their inclusion criteria midway through the study. The ARISE trial was conducted in multiple centers, but they had low recruitment rate, about one patient in each center. And the PROMISE trial only recruited about 1/3 of their eligible patients. So the fact that clinicians on average use 30 cc per kg pre-randomization in these studies was likely based on the original study, which is the RIVER study, which was conducted in 2001. And furthermore, these trials, the PROCESS, the ARISE, and the PROMISE, actually provided evidence that liberal fluid resuscitation does not improve patient-centered outcomes. Yet the guideline is still referenced in these studies. Next. Can you just show all the studies? Thank you. So these are a list of randomized controlled trials that were done to evaluate fluid therapy in sepsis. The first one is the FEAST trial. looked at mortality after fluid boluses in African children with severe infection. This was published in 2011. It was a multi-center study, over 3,000 children, and it actually showed an increase in mortality with liberal fluid use at 48 hours and 28 days. The next study, the classic study, looked at restricting volumes of resuscitation fluid in adults with septic shock after initial management. This was also a randomized control trial, and it was conducted in an ICU setting, had about 150 patients, and it showed worsening acute kidney injury significantly lower in the fluid-restricted group. The next study was published in 2017, looked at effect of an early resuscitation protocol and in-hospital mortality among adults with sepsis and hypotension. Another randomized control trial of about 200 patients, which showed an increase in hospital mortality with liberal fluid therapy, as opposed to if this was left to the discretion of the treating physician. And the last trial, which is the RIFT trial, it stands for Restrictive IV Fluid Trial in Severe Sepsis and Shock. This actually showed no difference in mortality between the two groups, which is the liberal fluid and the restricted fluid protocol. Next slide, please. So
You have 30 seconds, Kulthum.
Okay, so we're not saying that there is a right approach for fluid resuscitation, but the approach needs to be reasonable. Next. So it's not about making the numbers on the monitor look pretty. It is about making the patient better. Next. 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 So the approach to fluid therapy should not be like a one-size-fits-all t-shirt. We need to tailor it on a patient-to-patient basis. Thank you very much.
Thank you very much, Kulthum. You spoke in 7 minutes and 10 seconds. I'd like to encourage you all to look if any hand was raised during the speech. So if you would like to take any questions, you can always do that. So now we move on to the second speech from the proposition team with Dr. Sarmed. You can start, Dr. Sarmed.
Assalamu alaikum. Is my voice clear?
You have some echo, Sarmed.
How about now?
Yeah, perfect. Go on.
Okay. So good afternoon. My name is Sarmed. Before I start, I just want to raise just one question. Is that regarding the previous presentation, what was her definition of resuscitated fluid? Also, another point is that there was no strong evidence that support that statement in pulmonary edema and ARDS. Okay, so moving to to the second point, which is about mean arterial pressure, and I will be with the host team proposition with the MAP more than 65. Okay, so first slide. Okay, so MAP is actually a key determinant of mean systolic filling pressure, which in turn is the major driver of venous return and cardiac output. Increasing MAP, therefore, usually results in increased tissue blood flow and augments the supply side of tissue perfusion. While some tissues, such as the brain and kidneys, have the ability to auto-regulate blood flow, MAP below a threshold, usually understood to be approximately 60 millimeter of mercury, associated with decreased organ perfusion, which tracks linearly with the MAP. So that's why the Surviving Sepsis Campaign 2021 again agrees with me and strongly recommend that for adults with septic shock on vasopressors, they recommend an initial target mean arterial pressure of 65 over higher MAP targets. And that was a strong recommendation, moderate quality evidence. So how did they rate into this? Next slide. Okay, so let's go back into 2014 with this multi-center open-label trial. They randomly assigned 770 patients with septic shock to undergo resuscitation with mean arterial pressure of target of either a high target, 80 to 85, versus 65 to 70, which is the low target. Their primary endpoint was mortality at 28 days. So what did they find? At 28 days, there was no significant difference between the mortality. There was also no significant difference in the mortality at 90 days. However, what did they significantly found? They found that Among those with patients with chronic hypertension, those in a high target MAP required less renal replacement therapy than those did in the low target group. Although the associated mortality was insignificant, but the significance of less renal replacement therapy in the high target MAP is actually very significant. It will open the door to more trials to support that statement. Next slide. So, yeah. So moving to another recent trial, the 65 trial, which I think the other team are very excited to share with you guys, is that this is actually a study that it is actually an open-label, multi-center parallel study about 65 ICU centers in the UK. They randomly assigned 2,600 patients into two groups, one permissive hypertension, and second is usual care. And their question was, does reducing exposure to vasopressors to permissive hypertension, i.e. MAP more than at 60 to 65, reduce mortality at 90 days in ICU patient more than 65? It's a big no. There was no strong, there is no difference in the need for advanced respiratory support, renal support, duration of ICU stay, cognitive decline, and even quality of life. So they ended up into targeting lower MAP did not have a statistically significant effect on mortality, renal function, respiratory function, and ICU active stay. They have also mentioned that there may be no harm, and I wanted to put 100 lines under the no harm. There may be no harm associated with permissive hypotension and the corresponding significant reduction in exposure to vasopressors. So they were not actually arguing about the 60. They were trying to prove that 60 may be safe. Okay? And one very important point is that most of the trials regarding MAP, their mean MAP in the study was actually higher than the group. For example, in the permissive hypertension group, their mean MAP was actually 66. So even if there was significance in that group, that was actually favors with the other group, thanks to that. Final slide. So pooled analysis of higher versus lower blood pressure targets for vasopressor therapy, septic, and vasodilatory shock. So this study was actually started by the suggestion that patients with underlying chronic hypertension. Next slide, Osama. Next slide. Osama, is this slide which? Okay, so final one is that pooled analysis of higher versus lower blood pressure targets for vasopressor therapy and septic vasodilatory shock. Actually, in that study, it was raised by the suggestion that patients with underlying chronic hypertension and atherosclerosis may benefit from higher targets. The significance of this study is that they have found that the higher MAP might increase the risk and mortality, but after 6 hours, in the initial 6 hours, there was actually balance between the risk as well as the benefits of higher MAP. So I will end up by what did the surviving sepsis complaint has ended with is that given the lack of advantage associated with higher MAP target and lack of harm among elderly patients with MAP target of 60 to 65, they recommend targeting MAP of 65 in the initial resuscitation of patients with septic shock who require vasopressors. So that was about it. Thank you so much.
Thank you very much, Sarmed. So you spoke in 6 minutes and 40 seconds. Okay, so now we move on to the second speaker from the opposition team, Dr. Sarah Hussein. Welcome, Dr. Sarah. You can start.
Hi, good afternoon. My name is Sarah. I'm from Rashid Hospital Emergency Department. I'm part of the opposition team. We're advocating for less aggressive resuscitation of sepsis patients. I'm specifically talking about why a MAP of 60 is not dangerous for sepsis patients. So thank you for the previous speaker. You kind of proved my point, actually. I agree with 80% of what you said. The rest 20% I will try to persuade you. So can you go to the next slide, please? Okay. So I am starting by saying this, by mentioning this very famous quotation we have in statistics. Correlation does not equal with causation. There is no, and I mean no, high-power study that exists that shows a map of 60 is more harmful than 65 without having other significant confounding factors that were not accounted for. This is including, but not limited to, aggressive resuscitation once the map drops below 65. So it's entirely possible that the patients are dying because because of the aggressive resuscitation rather than the decrease in MAP itself. What I'm trying to prove here that a MAP of 60 is not dangerous. I'm not trying to say bring your MAP down to 60. That's the important part of the debate. Most studies that are done that prove MAP of 60 are harmful, they are retrospective. They're not of high quality, which makes it more difficult to effectively prove the danger in lower MAP targets. Physiologically, it doesn't make sense if you say a MAP of 66 is completely normal and a MAP of 64 is dangerous. Human physiology does not work in absolutes. It's more likely that the normal range tapers down and that there is no single optimal MAP for every critically ill patient. I want to bring your attention for Dunzer et al. From 2009. Arterial blood pressure during early sepsis and outcome was the title. What they found was norepinephrine load was associated with mortality, a relative risk of 1.83, 95% confidence interval between 1.4 to 2.38. This load was also associated with several disease-related events. These associations were independent of age, prior history of hypertension, comorbidity. So the norepinephrine load, by their own terms, rather than the MAP, was associated with impaired outcomes. Meta will talk about this in a while, but I just want to mention this earlier. Sepsis spam, Asfar et al. Was a 2014 study, randomized control trial. There was no significant difference in fluid intake between the two groups. Patient and research staff were blinded. It was conducted over 20 months in 29 centers with 776 patients. And the inclusion criteria, it negated the effect that I was talking about earlier, which made the other papers weak. The primary outcome was no significant difference in mortality at 28 days. Secondary outcome was no significant difference in mortality at 90 days, no significant difference in serious adverse effects. High MAP had significantly higher rates of new atrial fibrillation. And yes, in some subgroup analysis, they found in chronic hypertension, doubling of creatinine levels, a number that needed renal replacement therapy. But they conducted another trial, which was much larger, the MAP65, where they did not find this finding. I'll talk about that in a second. Moving on to the OVATION trial was Lamotrigine et al. 2016, 118 patients from 11 centers. This was a pilot study. They just wanted to check the feasibility. Rates of cardiac arrhythmias and hospital mortality were not different between the two groups. Among patients aged 75 and older, a lower MAP target was associated with reduced hospital mortality. Next slide, please. Okay. So this is the main trial I want to talk about. Thank you for bringing it up earlier. This is the MAP65 trial. It was conducted in 2020, and it had good internal and external validity. Next, please. The title of their study is, what is the effect of mortality at 90 days of reducing exposure to vasopressors through permissive hypotension in ICU patients age 65 or older? They had 2,463 patients analyzed from 65 ICUs in the United Kingdom. They had allocation concealment, intention to treat analysis, great follow-up of patients. It was a really excellent study. It was a large, multi-center trial in diverse group, standardized the care that was provided between both the groups. So again, the fact that made the other papers weak is that the fluid utilization in this study was completely the same between both the groups. They were well balanced in terms of randomization as well. Its primary objective is mortality and MAP, so the study was adequately powered and adjusted for the clinically significant factor that I would care about as a physician. Potential for mortality benefit in patients with chronic hypertension was also seen, but again, this is something that would probably need further studies to confirm, but it was seen. Next, please. On the left side of your screen, you can see the forest plot. It favors permissive hypotension. And on the right side, you can see earlier time to discontinuation of vasopressors. And there was no significant difference across almost all parameters, especially among patients with chronic hypertension. Can you ask your question, please, Husna? But just quickly, if you don't mind.
Husna, can you ask? One question regarding this study. What I know that the mean MAP was actually above 65.
I will answer your
but
question.
they sustained. Second one, it wasn't that a great study. The author himself was not confident to say that it is a good study.
Thank you. I heard that he brought those points up earlier, and I will talk about them in just 1 second. So again, let me mention this part. Yes, the MAP study, the MAP they actually found was different. But I want to remind you that the sepsis spam found no mortality difference, even with a considerably greater separation, 80 to 85 versus 65 to 70. Now, I know those are not the numbers we're looking for, but they had a huge difference, and they found no mortality benefit either. It was true that the MAP was usually higher than 60, but this is also reflective of the type of patients we're actually seeing in the emergency department. Higher differences in MAP, again, did not have any significant mortality difference in sepsis spam. And in either ways, the control group in this case still had a higher MAP than the intervention group by around 6 units. So it was a significant difference. All right, so moving on to next slide, please. Okay. Primary outcome, no significant difference in 90-day mortality. Secondary outcome, no significant difference in discharge mortality from the ICU or from the acute hospital. Next, please. Okay, sepsis spam, again, they found chronic hypertension with renal dysfunction, but in 65 trial, which was much larger in size, they did not find this finding. And no significant difference was found across all parameters, raising the question, why are we still aggressively managing hypotension in a MAP of 60? I want to answer a question that you raised earlier.
You have 30 seconds, Victor.
Okay, I will just wrap it up. I'm done with the MAP. I just want to talk about the hypovolemia. In healthy volunteers, around 70% of fluid extravasates in 30 minutes. So I want you to show me proof that the fluid that you're giving is actually showing a sustained benefit, not the full management. I want to also mention that ARDS, one of the most common causes of ARDS, and I can show you citations for this, is non-pulmonary sepsis. So I don't know what you're talking about when you're saying that there's no high-quality evidence. We have very much high-quality evidence that people are getting ARDS and they're dying from it. I can show you the literature if you'd like. Thank you very much for your time.
Thank you very much, Doctora. You spoke in 7 minutes and 5 seconds. So now we move on to the third speaker from the proposition team, Doctora Noura Al-Alawi. Doctora Noura, you can go ahead.
السلام عليكم جميعا. Okay. السلام عليكم جميعا. Before to move to my point, I just want to clarify or to add to the previous comments from Sarmend and Muzna. First, I want just to ask about regarding, you mentioned that atrial fibrillation, the rate was higher in the higher MAP, but you didn't define how higher MAP. We are speaking about 65, not higher MAP of 70 or 75. And regarding the 65 trial, as they mentioned before, first it was ICU setting, it's not in ED setting. Second, as Muzna said, the median age in that group in the permissive hypotension was 66, it's not 60. The third one, they clearly state, the author themselves, they clearly state in their conclusion, it may be benefit. They were not confident enough to state a clear conclusion that it's clearly benefit in mortality. So can we move to my point? Next slide, please. So I will speak about timing of pressure, and the early is the better. And what I mean by early is before completion of 30 ml per kg fluid boluses. Next slide, please. And there are multiple reasons that favor starting norepinephrine early. The first one is early norepinephrine administration corrects hypotension faster. Once we correct hypotension faster, this will prevent prolonged severe hypotension. As many studies shows, not only the degree of hypotension, but the duration of hypotension that matters in patient outcome. There are recent trials, and how we can achieve basically, or how can avoid prolonged hypotension is by starting norepinephrine early. There is a recent trial that was published in 2019, titled as "Early Use of Norepinephrine Improves Survival in Septic Shock." Early than early. They clearly state this or shows that achieving MAP of 65 was shorter once we add norepinephrine early along with the IV fluid. Next, please. The second reason is early norepinephrine infusion increases cardiac output, and this is by several mechanisms. Now, the beauty of norepinephrine, it's alpha-1 agonist and beta-1 agonist. Alpha-1 agonist, it will cause venoconstriction. Once we have venoconstriction, it will increase the venous retain. Venous retain increased, then preload will be increased, so cardiac output definitely will be increased. The second mechanism through beta-1 agonist, which is act as increase the cardiac contractility, which lead to increase the cardiac output. And it acts as synergistic effect with IV fluid. The third mechanism is basically increasing systolic LV and RV systolic function by increasing the coronary perfusion pressure due to increase the diastolic arterial pressure. And all this mechanism, it's not only theoretical, it has been proven through several studies as mentioned in this slide. Next, please. Early norepinephrine, the third reason is early norepinephrine administration improve microcirculation in cases of severe hypotension. And this is basically by increasing organ perfusion pressure. Gorg and his colleague did a prospective study that showed that there's significant improvement in muscle tissue oxygenation once we increase the MAP from 55 to 77 by increasing norepinephrine dose. Next, please. The fourth reason is early norepinephrine administration prevent harmful fluid overload. And what I mean by harmful fluid overload is the above 30 ml per kg fluid boluses. So how we can avoid that is simply by adding norepinephrine early, so we can limit the fluid use in resuscitation, as it's proven by the refresh trial and early versus delay administration of norepinephrine in patients with septic shock. The last, but the most important reason is improvement in patient outcome. We know that despite the advance in medical care, we still have higher mortality rates due to septic shock. And it has been proven that early norepinephrine administration is an independent factor associated with mortality. The earlier, the better. Now, there are recent trials published in 2020 and titled as Delayed Vasopressor Initiation is associated with increased mortality in patients with septic shock. And the second trial is effect of very early start of norepinephrine in patients with septic shock. Both of them showed improvement in mortality at 30 and 28 day mortality. Besides that, the study that I showed you before, titled as Early Use of Norepinephrine Improve Survival in Septic Shock Earlier Than the Early, they compare adding norepinephrine along with the IV fluid before 3 hours to compare it to after 3 hours. And they also shows in-hospital survival rate improved with the early norepinephrine group. Plus, they didn't find any adverse event from starting norepinephrine early. And the landmark study in septic shock, the sensor study that was published in 2019, also shows improvement in morbidity in terms that reduce the amount of or the cases for cardiogenic pulmonary edema and new onset arrhythmia was low in the group that was giving norepinephrine early and within 2 hours. I think by this reason, it's clearly now why we need to start early, why we need to start norepinephrine early before 3 hours. Thank you.
Thank you very much, Dr. Noura. You spoke in 5 minutes, 40 seconds. Now we'll move on to the last main speech of the debate with the third speaker from the opposition, Dr. Maytha Al-Ali. You can go ahead, Dr. Maytha.
Assalamu alaikum, good afternoon. This is Dr. Maytha from Rashid Hospital. I'm a Syrian resident. So I'll be taking the last part of this debate. We are speaking about delayed or late vasopressors. So if we come to the studies, we have focused on the rationale of the use of different vasopressors. However, the timing of initiating those vasopressors is crucial in the treatment of septic shock, but it was not stated clear. So the present data have no definition of what's early or what's late when it comes to the timing of starting vasopressors, or to be specific, norepi, since it's the most agent studied. So what do we really mean by late? So does it mean after fluid boluses, as the proposition suggested? Is it after 1 hour? Is it after 2 hours of the resuscitation? Or is it if MAP of 65 is not achieved? Next. So to start with the To start with the highest level of evidence that the proposition should take on her side, it was a systematic review and meta-analysis was published in 2020. Next. So the present data shows that the time from the onset of septic shock to the initial norepinephrine administration is important determinant of survival, but no recommended time to start norepinephrine support was not clearly stated. Next. So as we can see in this systematic review and meta-analysis, it included 3 RCTs and 2 cohort studies, in total of 928 patients, which is a small number. So if you look at each one of them, they have a different time to set for an early or the late group. But if we compare them to each other, for example, you take the first one, they initiated the vasopressors in less than 2 hours, and the fourth one, they started the vasopressors with the less of 6 hours. So if we put them together, actually, one of them will be late and the other one will be early. So they concluded that a prompt and aggressive norepinephrine administration should be considered as a part of initial resuscitation therapy, but there was no certain timing set. So further RCTs, larger scale, are still required. Next. So as the proposition stated, the sensor trial, which we all know when it comes to septic shock. Next. So sensor trial has limitations. It is a single center trial. It only included 310 patients in total, 155 in each group. Next. And the next. So it is a double-blinded RCT, but was it really blinded? Because the attending physician in the trial could allocate the patient that were receiving the norepinephrine by the significant increment in the blood pressure. And the time into administration, so time to vasopressor in this trial was 93 minutes on average, where if you compare it with the Surviving Sepsis campaign in 2018, the 1-hour bundle, it counts as late. Plus, the study drug, the norepinephrine, was infused over a period of 24 hours without titration. So that may affected the treatment outcome and results. Next. Okay, so the sensor trial concluded that there is a significant association between norepinephrine and increased shock control, which was their primary outcome, but further studies are needed to confirm those findings. It needs to be validated, and further studies should investigate the early norepinephrine with the organ dysfunction and mortality. Next. So when it comes to the Surviving Sepsis campaign in 2018, the 1-hour bundle recommend to start norepinephrine within or after the resuscitation with 30 ml per kg of fluids, if MAP of 65 is not achieved. But in 2021, next, it says nothing about the timing to start vasopressors. They focused on the time to antibiotics very much, but nothing was there about time to vasopressor. Next. So until there is a clear definition about what's early and what's late, we have no point of debate right now. Thank you.
Thank you very much, Dr. Maita, for your speech. So with this, we end the main speeches.
Can I say one more question? I think we have time. I raised my hand. No one let me in.
So now this is up to Dr. Maita if she wants to take the question or not.
It's actually a compliment more than a question. Thank you very much, Dr. Maita. You are on our team. You supported us too much.
Thank you, Mizna. We'll carry on now. So, so as I was saying, we ended up our main speeches. We move on to the reply speeches. And for the reply speeches, we'll start with the opposition first, and then we'll move on to the proposition. So from the opposition, we have Dr. Kulthum giving us the reply speech. You can go ahead, Doctor.
Sorry. All right, I'm going to start. So sepsis has a huge global burden with about 1 million deaths worldwide per year. It also represents a high health cost, and most countries necessitate ICU admission if the patient requires vasopressor support. So it's therefore an important area of research, and we need to optimize therapy based on sound research evidence. Aggressive fluid resuscitation has long been considered the cornerstone of treatment of septic shock. However, there is no sound scientific evidence to support this treatment approach, but there is evidence to suggest that such an approach is harmful. An individualized, hemodynamically guided, and fluid-restricted approach to fluid therapy is more likely to improve patients' outcomes in severe sepsis or septic shock. And the fact that the Survive in Sepsis guideline, which was recently updated about 3 weeks ago, downgraded their recommendation on fluid therapy from strong recommendation to a weak recommendation with low quality evidence reflects this. I also couldn't help to notice one of your speakers, your third speaker, also did make a statement about starting early epinephrine in order to avoid fluid overload. So basically, fluid overload is a concern with aggressive fluid therapy. The Survive in Sepsis guideline also recommends targeting a MAP of 65 in patients with septic shock. There are no studies comparing MAP of 60 with MAP of 65. Therefore, no studies suggest that a MAP of 60 is harmful. Until more data is available, the current recommendation of the target MAP of 65 during critical illness should be viewed with caution, in my opinion. There's no proof that a MAP of 65 is safe for ED. Referring to the issue of the trial 65, the authors were not saying that their data is wrong. They were simply saying that they need more studies, as this is just a single study. It's a potential for doing more studies, but they were not saying their data was wrong. Lastly, vasopressors are not without risk. We all know that they may reduce blood flow. They cause vasoconstriction in the vascular beds. This can lead to necrosis in the peripheries, in the GI tract, your gut, kidneys, etc. The Survive in Sepsis guideline is very clear on the choice of the first-line agent, which is norepinephrine. But when it comes to vasopressor use, the recent guideline, the one released 3 weeks ago, is actually less precise about the appropriate timing to initiate norepinephrine. So the question on optimal timing still remains. Thank you.
Thank you very much, Dr. Kulthum, for your speech. Now we move on to the last speech of the debate. We ended with Dr. Haja giving us the reply speech for the proposition team. You can go ahead, Dr.
Okay. So as we can see, we do actually, both team agrees that the importance of sepsis and septic shock, and the importance to target different things, fluids, vasopressors, and MAP as well. Otherwise, we would not have this debate from the beginning. So as we said, I was waiting for the opponent team for a definition of how slow and how minimum is a fluid. Is it 5? Is it 10? Is it 15? For how long? 1 hour, 2 hours, 3 hours? I was waiting for a definition. That's why what we need to negotiate and we need to establish what is the definition of slow. Other points regarding the capillary leaks and pulmonary leaks as well. We saw that different observational studies done in end-stage renal disease, in heart failure. They still emphasize the importance of fluid resuscitation in septic shock-induced patients. So, are we worried about the capillary leak and pulmonary leak? Definitely, we are worried about. But did that actually push them into higher mortality? I doubt it. Another thing, again, I was also waiting for the definition of how slow or late vasopressor to be started. Is it after polysis or after how long? Still, there is no specific time. When we talk about the phase trial, it was an amazing study actually, which was done. But what about the later studies, which should follow their steps? Is it still pending in the ethical approval office? There is a lot of drawback in that study. Yes, it was brave to do it. Maybe it's the only study that compared a specific amount of polysis, 20 ml of normal saline versus 20 ml of albumin, 20 ml and versus no fluid resuscitation. But with that, great. protocol I'm anticipating now, it was conducted in the 2015, as I remember. Now it's 2021. Where are the other studies which followed their steps to improve the outcome and to prove their point as well? When it comes to MAB as well, so 60 versus 65, 60, do we actually risk keeping a patient a MAB of 60 or less and risking these patients to have kidney injury and others even adverse events of low MAB in such patients? I do agree about the physiology that you spoke about. It was an amazing, but in an experimental studies, as long as they cannot run it in humans and induce hyperdynamic status. They did an experimental studies in animals, mice, pigs, different, and the result was actually different. For example, mice, they responded very well to fluid policies when they induced hyperdynamic status as a picture of septic shock, while pigs did not. Are humans the same? We cannot tell. So I believe yes. Even though the survival sepsis campaign went weak recommendation, I doubt anyone next day in the emergency, they will go and say, no, this is a septic shock, don't give them 30 ml, don't give them fluid, just be slow. Let's wait and see what's happening. That's too risky to do it. That's all. Thank you.
Thank you very much, Dr. Hajar, for your speech. And thank you for both teams. It was an amazing and a very interesting debate. And all the comments in the YouTube, they are applauding you guys. So thank you.
And the speaker, it was really interesting track. I enjoyed a lot.
Dr. Saad, sorry to interrupt. If you can kindly open your video, please.
ضروري الفيديو.
ضروري جدا جدا.
لا 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 خلينا هاي voice يكفيكم.
خلاص, it's fine. All right.
So thank you everybody. It was really very interesting debate. But eventually we had to choose one team as a winner. So to start with, I have to say that the topic is really not easy. It was really, really debatable topic, and both teams did extremely well in terms of defending their points, and the evidence for that component of the debate is still evolving. It's not actually crystal clear evidence whether with or against in a firm way. So I have to be frank with that. It wasn't an easy job for both teams. So most of the experts in the field of management of septic shock usually will advocate for an early start of vasopressors and avoiding unnecessary load of fluids, boluses, which could be harmful in some circumstances. Like you have to put into consideration lots of patient variation, and that's why you have to have really a very good volume assessment on these patients, and that's why ultrasound is becoming extremely handy and required on these patients. It's your volume assessment which will be kind of guiding your resuscitation, how much volume they need and how much volume depleted they are, because a heart failure patient could be septic, but he is not really volume depleted, and these patients usually benefit more from inotropes and vasopressors compared to just loading them with fluid and so on. So management will be much more guided if you really have a kind of a uniform, reliable way of assessing their volume status. So saying that, أنا أعرف أنتم متحمسين and you are waiting. So the opponent team really chose a better quality evidence, and they analyzed it in a very clear, nice way and presented their points and defended it really in a good way. They were very organized in terms of the flow of ideas and thoughts. Their slides also were really presented in a good way. They indicated even the weaknesses and the evidence they chosen. And for that matter, the debate winner is actually the opposition team. Congratulations, UAE, you won the debate, especially for your great team work. That being said, the opposite team actually did very good job in answering and defending the points you raised as well. So as a conclusion, Regarding the topic itself, IV administration should be tailored based on a patient individually rather than just generalized approach. One size does not fit